So good evening, everyone. Well, I do not have any video in this particular talk. The reason is very obvious because my topic is prevention of slow flow and not treatment. So I can never prove that what I have done has actually prevented slow flow. So it's going to be more of a didactic talk, and this is something you come across. It's not something which makes you feel happy when you are doing the plasty yourself. That's a slow flow or no reflow. So this is a no reflow is characterized by angiographic evidence of slow or no antegrade epicardial flow, resulting in inadequate myocardial perfusion in the absence of any evidence of mechanical vessel obstruction. And this may occur in the setting of acute coronary syndrome, as in primary PCI, or in a stable patient who is undergoing an interventional procedure. Maybe PCI, complex PCI, maybe rota, and it's due to a functional and structural alteration of the microcirculation, the coronary microcirculation. However, in in a proportion of cases, it may regress spontaneously. And if you ask me about the incidence, it's about 5 to 60%. It has been described, a huge vast range. And the reason is like depending on the patient population that's been studied. I mean, if you only study patients who had an atherectomy done, maybe high, as opposed to like maybe in a stable patient where you have just use a balloon perhaps. So incidence is higher in primary PCI for STEMI, and cephalous venous graft PCI, and rotational atherectomy in highly calcified lesions. Now, it's very interesting to look at the pathophysiologic mechanisms. Broadly, there are three. That's ischemic reperfusion injury. It could be microvascular obstruction resulting from distal atherothrombotic embolization, or even from intravascular plugging, which may happen from leukocytes or platelet microthrombi. And thirdly, it could be microvascular spasm. Most of the time, it's not a single phenomena. It's all these three together. And which mechanism will be predominant, that depends on the setting in which it has occurred. Now, I've just made an attempt to elaborate like what happens actually in slow flow. Now, initially, of course, there is a ischemic injury, and this initial severe ischemia causes damage not only to the cardiomyocyte, but also to the endothelium. And endothelial damage from ischemia results in endothelial necrosis, cell necrosis, resulting in destruction of tight junctions and loss of vascular integrity. So there is extravascular edema, and this results to vascular compression and a reduction in the microvascular lumen. Also, at the same time, ischemia causes endothelial dysfunction. So release of nitric oxide is reduced, and this impairs the endothelium-dependent vasodilation. Now, ischemia to cardiomyocytes results in cell necrosis and cardiomyocyte swelling. This again may compress the intramural vessels. Now, ischemia is followed by reperfusion, and this reperfusion injury is, it actually worsens what has been already been done by the ischemic injury. So reperfusion is associated with production of oxygen-free radicals, which further cause endothelial disruption as well as inflammation. It causes migration of neutrophil and platelets, forming microthrombi, which obstructs the lumen of the microvasculature. Also, reperfusion is associated with autonomic dysfunction, and there is intense alpha-adrenergic receptor-mediated constriction of the coronary vessels, which results in microvascular spasm. And the third is, of course, the distal atherothrombotic embolization, which happens more in a stable PCI setting. So where we do a PCI of a complex plaque, and there is distal embolization of the microthrombi and plaque components, which causes occlusion of microvasculature, resulting in microinfarcts, which again promotes release of pro-inflammatory and vasoactive substances. And this further causes damage and microvascular and vascular spasm. Now, no flow, reflow is not good for you. It's bad. It increases it worsens the outcomes. So the mechanism perhaps is if blood flow cannot enter or leave an area of necrotic myocardium, then the cells such as macrophages, which are actually necessary for removal of debris, they cannot function. and the humoral factors necessary for proper healing cannot access the tissue. So it would result in poor healing of the infarct. So in short term, that can cause increase in acute heart failure, incidence of acute heart failure, malignant arrhythmias, cardiogenic shock, and death. Also in the long term, it would result in adverse left ventricular remodeling, resulting in congestive heart failure, rehospitalization, and MACE, including death. Now, the diagnosis is usually done from coronary angiography. At times, when there is slow flow instead of no reflow, you can take note of the TIMI flow, the frame count, or the myocardial blush. If, say, you have thrombolized the patient and you find the patient's having, the ECG, there's no ECG resolution or resolution less than 50% within, say, after 60 to 90 minutes, then you can say, well, it's indicative of no reflow. And also there are other ways to do, like gadolinium contrast enhanced cardiac MRI, contrast echo, or nuclear imaging.